Welcome back to Get Your Man On, where I have started a new band called Sex Hormone Binding Globulin, or SHBG. We are starting a world tour, Huntsville, Alabama, August 4th, with the Bee Gees. Just kidding. Okay. We're here with Dr. Alderson, Tom Alderson, urologist. And Doc, what emerging treatments or therapies for ED are you excited about?
Since I'm not in the active practice of surgical intervention anymore, I'm attuned more to non-invasive procedures, consumption of medications and application of medications and injections of medications. But there's still adequate need in the community for surgical procedures because it is a last tier of treatment that's available for men with ED. There are some new drugs that they're coming out, but as you well know, they're patents on drugs, and when the patent runs out, I think it's 7 or 8 years.
Right.
All you have to do to get a new patent is change one of the radicals on the ring, and it becomes a new drug, and hence a new name, and hence a new patent, and hence a new purchase price.
Oh.
So in my search of the literature that I've looked at in the past few days, there are 3 to 4 new drugs that are out there that are being investigated, that are in phase 1 trials currently that aren't FDA approved. But once they get through the phases and once they have the comparison studies and have thousands of patients that have tried it and prove that it works, then they'll be introduced into the urologic community or the community at large and be available for consumption.
That's cool. What's like your go-to, would you say, the treatment you do the most when you're treating ED?
I'm somewhat old-fashioned. When I see a patient in the office, I first of all look at their paperwork and look at the medicines that they're on, look at their age, and look at the length of time they've had difficulty with erections, and look at the quality of their erections that they're having currently. And from there, you pretty much can guide yourself and have an idea of what you're going to do before you even go into the room and see the patient. But after you've seen the patient, interviewed him, and done a physical history and physical on them, I usually, being old-fashioned, I usually start out with something simple and then progress from tier 1 to tier 2 to tier 3, which is unlike what has been suggested that we do by the American Urological Association. They've taken an completely opposite stance. They say that when the patient comes in, tell them about all the different options and let them choose. So if a patient comes in, he's 30 years old and he's healthy, and he wants a penile prosthesis at 30 years old.
No.
Yeah, it just doesn't make sense to me.
That makes no sense.
To guide them in that direction. So I'm still old-fashioned and still proceed from something simple to more complicated, to higher doses, to injectables, which is a tier 3, and then to surgery, which is the tier 4, the last step in the treatment of ED.
Well, all 30-year-olds who don't want a third testicle or a prosthesis, thank you for doing it that way. I know that for a fact. I can't tell you how many guys call our office. They're like, I got an implant. Can you just do anything for us? And we're like, no, you got the implant. There's no going back from that. So I appreciate that. But this Trimix, I've given, full disclosure, I've given over 10,000 of these doses. That used to be all I did. I was just the injector. I saw a billboard on the interstate where it was like, here, we have our new injector, and it's this young 25-year-old woman, and they're talking about face stuff. But I felt like, I was like, what if I put myself on the board? I was like, I'm the injector of Trimix. It's this penile injection that guys freak out about, but I'm always like, you got to try this stuff. Can you tell me a little bit about Trimix?
It's a great drug. It's unfortunately it's not FDA approved for the Trimix itself. It's a combination of 3 medications like papaverine, pentolamine, and alprostadil.
Well, it'd be really hard to get all thousands of combinations approved, right? Because you'd have to get every single one approved. I mean, that's probably why that's happened. That's an expensive process, and
it is expensive, and The only one I think that's approved by the FDA is alprostadil, which is labeled or sold under Edex or Caberjet, I think, are the two main products that are available. But there's the single use, and then you've got the bimix, and then you've got the trimix, which is the combination of the three drugs that mostly are vasoactive. They increase the cellular levels of cyclic guanylene monophosphate and cyclic adenine phosphate. But it decreases the amount of calcium that's in the cell and causes a dilation of the muscles to the penis that surround the blood vessels, and hence you have an increase in the blood flow to the penis. It's good because it doesn't have many side effects.
Right.
The main side effect is the serious side effect is a thing called priapism, which we rarely see, and it only occurs in like 1 or 2% of the patients. And it's usually because they haven't been tested in the office. Yeah. That's what we like to do. We like to give a test dose in the office and see how it's going to respond or how it's going to react. And we're looking for maybe 50% erection with our first injection. And from there, we can titrate the medication up or down depending upon the response that you get.
Right. Yeah. And it's pretty miraculous. I always say, we can do a designer erection. We can design this erection to last 30 minutes or an hour and increase the firmness, adjust the firmness, and it's the Gucci of erections.
And when I tell them that, they say, "Oh, you can really do that?" But most men, they want 100% erect penis. Yeah. And the time length is so variable. Some men want 10 minutes, some people want 2 hours, and we can design the combination or the mixture of the medications that we use to fulfill that need.
Yeah, and I know this stuff's been around a long time, and I think I've heard it's called the gold standard of ED treatment, right?
I remember when it first came out.
Yeah.
In the early, I think, 80s, like 83 or so, there was a gentleman who was giving a talk at a urologic convention and dropped trout and gave himself an injection and got an erection in front of the audience.
What?
That's the story that I hear.
That's incredible.
If he can get an erection in that environment, right, it should work.
Yeah, it's incredible how well it works. Again, back in the day when I was doing all that stuff, guys would be like, "I'm not doing that. I'm not injecting myself in the penis." I'd be like, "If it hurts, you can punch me." My claim to fame is I've never gotten punched because it's just not that big a deal. But so priapism, people always worry about that, or actually no one really worries about that. But you hear the commercials about it. If you get, and I think that's what makes this different, is doing that test in the office, not just sending them out to do it at home. That's a big deal, is to make sure you go to someone and get the test first.
Yeah, a lot of these clinics will just send you home with a syringe or a bottle and tell you to use it.
Yikes.
With no instructions.
Ugh. Dr. Alderson, thank you again for being on. Always a pleasure. Can't wait to have you on again to talk through some more stuff. Next week, we're going to talk big time. You're not going to want to miss the show next week. I'm just going to tell you that right now.